Welcome to Fertility 101. Today is meant to give a very broad overview of what we do at our practice, and to kind of give a general outline of some of the things to think about for people who are considering fertility testing or may need treatment, and happy to answer at the end any questions anybody has. So my name is Laura Meyer. I'm a reproductive endocrinologist and a fertility doctor at Illum Fertility. And we are a practice that is located in both Westchester and Fairfield counties in New York and Connecticut. We have 9 board-certified fertility doctors here, and we have a really comprehensive program with an on-site surgical center, an embryology laboratory, whole fertility and wellness program. So we really try to offer very comprehensive care to our patients. So what exactly does that mean? Well, there's lots of different things that we have here at the practice for our patients who are going through fertility journeys. One of the most common things that we do to start out is to do fertility testing on patients to figure out what may be going on, if they're having difficulty conceiving, or how we might be able to best help them. We do some fertility preservation treatments, such as egg freezing and sperm freezing and embryo freezing. We do IUI, that's intrauterine insemination treatments. We also do IVF, or in vitro fertilization, to help people to become pregnant in that way. And we also have a very robust third-party reproduction program, which includes things like donor conception, so donor sperm, donor egg, surrogacy. So we really can help people along their path to parenthood in many different ways. And one thing that I think is really unique about our practice and that I'm very proud of is the really comprehensive and holistic support that we offer our patients. So in addition to the medical testing and treatments that I mentioned, we also really believe in supporting and treating the whole patient. We have awesome acupuncturists in our practice who work with many of our patients as they're going through this process. We have a network of counselors in the area, really who have expertise in fertility and can be a helpful support to our patients who are in the situation. We have 2 fabulous nutritionists who help our patients, in terms of optimizing things from a lifestyle perspective and taking into consideration some of those things as they're working towards parenthood. And we also offer support groups for our patients. We realize this can be a challenging time for those who are facing infertility. And sometimes it's nice for people to be able to talk to others who are going through the same process. Okay, so a little bit about fertility 101 and some things to think about in terms of understanding what it means and what we can do to help. So the technical definition of infertility is trying to conceive for 6 months without success for women who are over age 35, or 12 months for those who are under 35. And it's important to understand that it's really a retrospective diagnosis in those cases. So saying that someone has infertility doesn't necessarily mean that they can't get pregnant or that they won't ever get pregnant. It really just means either that you meet one of those definitions and that it hasn't happened yet within a specified period of time, or that someone's going to need help in order to be able to achieve a pregnancy. So somebody who maybe needs to use donor sperm, or is in a same-sex relationship, or someone who's a single parent by choice, like these things as well will require assistance for somebody to grow their family. There's a few different components that we have to have in place in order to have a successful pregnancy. So we obviously need an egg, a sperm, and a uterus to carry the pregnancy. And just to take you through some of the anatomy and hormones and physiology and understanding how all of this works, this is a diagram of the female reproductive tract. So you can see the uterus here, and these are the fallopian tubes and the ovaries. And each month, when a woman releases an egg from her ovary, it is swept up into the fallopian tube. And if it fertilizes that month by sperm swimming up through the cervix and through the uterus and into the fallopian tube and having a fertilization, then the embryo that results will travel into the uterus to implant and grow as a pregnancy. From a hormonal perspective, what happens is that women have a group of follicles in their ovaries at the beginning of each month. And so follicles are the fluid-filled sacs that contain the eggs. And each woman will have a baseline group of these follicles. And normally what happens is that the brain makes a hormone called FSH, which causes one out of the group of follicles to be the dominant follicle for the month. And that's the one that's going to have the mature egg in it that will be released mid-cycle at the time of ovulation. So she has that follicle that will grow throughout the first half of her cycle, or the follicular phase. And the follicle produces estrogen as it grows. You can see that estrogen rising throughout the first half. That estrogen in turn causes the lining to thicken and to become ready to accept an embryo for implantation. When the estrogen reaches a certain level and the follicle is big enough in size, that estrogen will trigger a luteinizing hormone surge, which is another hormone that's made by the brain. And that's what prompts the follicle to ovulate. And that dominant follicle will release the egg. The shell of the follicle that remains becomes what's called the corpus luteum and makes estrogen and progesterone in the second half of the cycle after ovulation. And that would support a developing pregnancy if an implantation occurs. If there is no implantation, then what happens is that corpus luteum, the function wanes over time, and those hormones taper off. And as those hormones taper, that is what causes the woman to shed her lining, get a withdrawal bleed, and then the whole cycle starts again. So one of the most important things that we talk about in understanding the physiology of fertility is the quality and the quantity of the eggs in the ovaries and how those things change over time. So quality we cannot measure directly, but it is generally associated with age. And when we're talking about egg quality, we're mostly talking about the chromosomal content or chromosomal normalcy of the eggs, whether they have the right number of chromosomes or extra or missing chromosomes. And that proportion that are normal versus abnormal changes over time as women get older. Egg quantity, however, we can measure for women, and there's a few different ways to do that. We can do what's called the AMH, or anti-Mullerian hormone level, which is a hormone that is made by the small baseline follicles in the ovaries. So if someone has more eggs and more follicles, it's going to be higher, and fewer, it'll be lower. We can look at the day 3 FSH, or follicle stimulating hormone, which is made by the brain. That's part of a feedback loop between the brain and the ovaries. So if someone has fewer eggs in their ovaries, it's as though the brain has to work harder to sort of get things going. And so it makes more FSH, so that we like to be below a certain threshold. And we can count the follicles at baseline on ultrasound. So we have a few different ways of assessing that egg quantity. And it's important to understand that those measurements can be helpful to us in many ways. And certainly, for example, for people who might be pursuing fertility treatment, that enables us to understand how people may respond to medications or how to dose them. But they're not really fertility predictors in and of themselves per se, because if a woman is ovulating every month, usually when she's trying on her own at home, and we're talking about natural or spontaneous fertility, she's just releasing 1 egg a month in that scenario. So in that setting, whether she has a lot of other eggs or fewer isn't as important as long as she is ovulating regularly. But again, it does give us somewhat of a sense of how she might do if she were taking ovarian stimulating medications, or if she did an IVF cycle, whether she'd get more eggs or fewer eggs, which could affect success rates and things like that, but not necessarily fertility predictors in and of themselves, these measurements. And so when we talk about this egg quantity, as I mentioned, it's different from person to person, and we can measure it. But as women, as a general principle, women are born with all the eggs that we will ever have. So men make sperm on a continuous 3-month loop pretty much their whole lives. But for women, the maximum number is even before we're born. And it's just a normal part of reproductive biology that over time, that number of eggs decreases. So by the time we're born and then hit puberty and the reproductive years, it's declining. And then when we get to menopause is when we're sort of quote unquote running out of eggs, or we have very few left at that time. Quality, as I mentioned, is really mostly related to age and the chromosomal normalcy of the eggs, and therefore the embryos that result. And this is something that starts to have more significant changes in sort of the later 30s and even more so into the 40s. And again, we can't measure it directly, but we know that overall it does correlate with age. Okay, so when someone comes in and they're having difficulty getting pregnant, what are some of the other things that we can check? So we just talked about checking egg quantity. There are some other things we want to look at as well, things that can be evaluated in a pretty minimally invasive way to see if we can identify any potential issues that could be going on. So one thing is to check the hysterosalpingogram or HSG. This is a check of the fallopian tubes. We have a catheter that we place into the uterus and put some fluid into the uterus that you can see on an x-ray, and then take x-ray pictures of the fluid, hopefully filling up the cavity and spilling out of the fallopian tubes. And we also oftentimes do something called a saline ultrasound, which is to check the inside cavity of the uterus. This also involves putting a small catheter into the uterus, but putting some saline fluid inside and taking 3D ultrasound pictures of the inside cavity of the uterus. And this is to look for structural issues within the uterus, so abnormal shape of the uterus, polyps in the uterus. On this picture that I have up on the screen, this person has a very large polyp, this big white circle that's here right in the middle of the cavity that could affect implantation. Fibroids, scarring, things like this these are all things we'd be looking for on a saline ultrasound. It's also important to look at sperm health. So there are a number of different parameters we look at for the sperm. We look at the volume of the sample, the count or concentration, which is the number of sperm in millions per milliliter of sample, the motility, which is the percentage that are normally swimming, and the morphology, which is the percentage that are normally shaped. And what I care about the most when I'm looking at a semen analysis is what is the total motile sperm count. So basically how many swimming sperm are in the whole sample. And that sort of gives us a sense of what there is to work with. And above a certain threshold, the sperm is less likely to be causing an issue, but certainly as the motile sperm counts go down and decrease, that it can be one common reason that people may be having difficulty getting pregnant. So these are some of the tests that we can do to discern why someone may not be pregnant if they've been trying on their own without success. But there's really a lot of different things that can cause infertility and difficulty conceiving. Having ovulation that's irregular, the most common cause of that is PCOS or polycystic ovary syndrome. Age is one of the most common reasons as well. As I mentioned, that really affects egg quality very significantly and can make it more difficult sometimes to get pregnant. Issues with sperm, endometriosis, which is a condition that happens when cells from the lining of the uterus migrate to places outside of the uterus where they shouldn't be and can cause inflammation and other issues. Problems with the fallopian tubes, issues with the uterus. Sometimes we do all the testing and the results come back as normal. And while it can be a good thing not to find a problem, I know sometimes that can be very frustrating for patients, not having a concrete answer as to why they haven't been conceiving. Sometimes that can be that it's just taking longer for someone, or they're sort of on one end of the bell curve statistically. Other times it can be that there's a more subtle issue going on. That's one of the things that we don't have the capacity to measure in a non-invasive way. We don't have a way of looking at fertilization or embryo development or implantation or things like that. But even for people with unexplained infertility, we do have some really good evidence-based ways of treating it and helping people to become pregnant. And as I mentioned, there are other people who may just need assistance getting pregnant, for other reasons, or may need help to conceive. So as I mentioned, we really offer the full spectrum of treatment options at our clinic, and I'll just take you through a very basic overview about what some of those things are. We have everything from ovulation induction, or helping someone who maybe is not ovulating regularly to do so that they're able to time intercourse and get pregnant more easily. Intrauterine insemination, where we may give somebody medications to sort of boost ovulation or help them to ovulate more than one follicle at once, but then also pair it with an insemination where we take a sample of the sperm and place it directly into the uterus. In vitro fertilization, where we create embryos in the lab or outside of the body for eventual transfer. Sperm freezing or egg freezing for those who need that for fertility preservation. Conception with donor sperm or donor eggs, and surrogacy or the use of a gestational carrier. So there's really lots of things that we can do to help people to grow their families depending on, what is best for them in their particular situation. So I'm going to take you through a few of these briefly, but in a little bit more detail. So with egg freezing, this is something that we do to preserve a woman's fertility, either because maybe she has a medical condition like a new cancer diagnosis or something like that, that could put her fertility at risk, and to freeze embryos for the future, or sometimes just because she's at a spot in her life where maybe she's not yet ready to grow her family, but would like to do that in the future. She can take out eggs when at a younger age, which would have a better chance of success in the future than going through fertility treatments with her older eggs down the line when maybe she is ready to get pregnant. In order to do this, she takes some medications to stimulate the ovaries. These are a version of the FSH hormone that I described before that's made by the brain, but in higher doses to try to cause the maturation of multiple eggs at the same time. And then she undergoes a process called the egg retrieval to take those eggs out of the body, and the ones that are mature can be frozen for future use. And then later they can be thawed and turned into embryos if and when she's ready to become pregnant, and an embryo can be transferred into the uterus. Another fertility treatment that is common in the practice is what's called intrauterine insemination, or IUI. And so, as I mentioned briefly before, this involves taking a sample of sperm and processing it to pick out the best swimmers, so to speak, and then placing that sperm directly into the uterus. So we do a speculum exam as if you were having a pap, and clean off the cervix, and then take this small catheter, place it through the cervix and into the uterus, and put the sperm there, so it has a bit of a head start to where it needs to go. This is a pretty simple, minimally invasive procedure. These intrauterine insemination cycles, which are oftentimes paired with like an oral medication or something like that that the woman might take, tend to be less expensive than IVF, and again are a less invasive option. This could be a really good option for someone, for example, who maybe has unexplained infertility and is younger, someone who has a mild male factor, so a milder sperm issue, someone who's using donor sperm, those sorts of things. Those are some of the common reasons that somebody might do an IUI. Another very common treatment is IVF, or in vitro fertilization. This is a more involved process. It is a bit more invasive, expensive, that sort of a thing. It involves taking stronger medications, just like I described with the egg freezing process, to stimulate the ovaries, and doing an egg retrieval procedure to take mature eggs out of the ovaries. And then those eggs are fertilized with sperm in the lab or in vitro instead of in the body or in vivo, to create embryos. Embryos are cultured in the laboratory for several days until they reach the stage at which they can be transferred or frozen or genetically tested, or some combo of those things, depending on someone's individual plan. This does have a higher chance of success than something like a medicated, IUI cycle, but again is more expensive and invasive. So there are some scenarios where somebody might arrive at IVF after having tried less invasive treatments first if they don't work, or there are certain situations where it may be someone's best option if the sperm count is extremely low, or both fallopian tubes are blocked, or things like that. Then sometimes that's the best path to go forward. We also, as I mentioned previously, have a large, what we call third-party reproduction program, which is any sort of conception in which additional people are involved in the creation of a pregnancy. So a sperm donor or an egg donor or a surrogate. And people arrive at these for many different reasons. Someone may need a surrogate because they have a severe problem with their uterus, or they were born without one, or they had a hysterectomy, or they had a really serious complication during a prior pregnancy, or they're a male couple. There's many different reasons why that may come to be. Other treatments, such as donor egg, may come into play when somebody either has very few eggs, or is older and has very poor egg quality and has failed treatments with their own eggs. So that is an option that can help a lot of people to have a family that may otherwise have struggled to do so. And then donor sperm could be for a single mom by choice, or a same-sex female couple, or a heterosexual couple where the male does not have sperm. Those are some of the reasons that people may go down that path. And all of these options that I've talked about today are things that we would talk about in much more detail, depending on what makes sense for a particular patient when they come in for a consult. We kind of go through all the options so they can make the decision that's right for them, depending on their particular situation. So that's a very, very broad overview of what we do here, but here are some links to have a little bit more information about our program and our team. And we would love to help you in creating your family. Here's some information as well about our different office locations and how to get in contact with us to schedule an appointment. So I'll leave that up for a moment. And I am also happy to answer any questions that anyone has. Feel free to type them in the chat. I'm gonna stop sharing here so that I can see the Q&A, and I'll pull that up. So please feel free to type in any questions that you have if I can be of help. And then there was a question, is there a specific window on my cycle to start with you? Okay, so typically what we do is we see people for an initial appointment, which could either be in person or on Zoom, whatever is most convenient for you. You can reach out to our office to schedule, where we go through your history, talk about what's been going on, and then talk about what testing makes sense for you. The testing part is typically timed to your cycle. Usually you then would come in after that initial visit whenever you get your next period. We would bring you in on day 2 or 3, usually for like a baseline ultrasound and some of the blood work testing. And then depending on the scenario and what you need, might schedule, for example, that saline ultrasound and hysterosalpingogram, the fallopian tube test from there. So most of that timing is somewhat timed to when you get your period for people who have regular periods. If not, we can always pick a time for you to come in, but then the initial visit would be before that. I have another question about AMH level changing each month and what does it mean to have a low AMH but FSH in the normal range? Okay, that is a great question. So the AMH level is the hormone that's anti-Mullerian hormone, and that's what's made by the small baseline follicles in the ovary. So that was the hormone where if you have more eggs and follicles, it'll be higher, and fewer, it'll be lower. There's not like a hard and fast cutoff per se. Oftentimes we say we like to see it over 1, but there's a range, and it is expected to decline over time. So if I see somebody and they're 43 years old and they have a low AMH of 0.5, it may be that it is on the lower side, but that's not necessarily pathologic per se. That is sort of expected that that's what happens with age, because the ovarian reserve does decline with age. The FSH, or follicle stimulating hormone level, is another way of looking at the same thing. It's a hormone that's made by the brain. So if you have fewer eggs in the ovaries, because there's this feedback loop of hormones between the brain and the ovaries, if the brain isn't kind of getting some of the feedback in the way that it wants from all those follicles in the ovaries, and there's a lower number, it starts making more FSH and it goes up. So the AMH, we like to be above a certain threshold, FSH below a certain threshold. FSH tends to become abnormal in sort of more severely low ovarian reserve situations, meaning if somebody, and that one can fluctuate from month to month, the FSH. So if somebody has a completely normal great AMH, it would be very unusual for them to have an abnormal FSH. When the AMH is a little bit low or more borderline, I'm paying particular attention to the FSH because that can give me a little bit of a better sense of kind of what's going on and how severe it might be. The FSH definitely changes month to month. The AMH doesn't change as much, although there is some just general variability in the assay. So like if you sent it to 3 different places on the same day, or you checked at the same place a few months apart, there is some fluctuation there. And that the amount that it fluctuates to as you get into the lower end of the ovarian reserve, it can be sort of less helpful. So if somebody has had an AMH before that was 0.5, and then they came back and it was 0.3, or if it was 0.8 or something like that, that's not necessarily unexpected. Those could sort of be within the range of just, you're talking about small incremental differences. So that one we usually will check less frequently because the actual egg quantity that it's reflective of isn't changing sort of month to month per se. So we typically update that at least annually. But the FSH, especially if it's abnormal, you might check, you might check in subsequent months just to get a sense because of where somebody is and what range they're kind of living in with that. And that can be helpful in planning fertility treatments and things like that. Okay. I have another question here. My partner and I decided, okay, so this is somebody who is 46 years old and has periods that are somewhat irregular, and which sometimes in the mid-40s, if the periods become irregular, that could be, for example, a sign someone might be going into perimenopause, or periods may be spacing out for that reason. And this person is in a same-sex partnership. What are the chances? Okay, so the biggest issue as you get into your 40s, what makes it so much more difficult to become pregnant isn't necessarily so much the uterine piece of it or the carrying of the pregnancy, as much as it is the changes in the quality and quantity of the eggs. So if someone is otherwise medically healthy and doesn't have any structural uterine problems, people can actually do quite well in pregnancy, even into their mid or late 40s, but it's the getting pregnant that may be more difficult. So this question about IVF, it sort of depends. Unfortunately, the success rates of creating embryos at age 46 are quite low. But if somebody who was 46 wanted to carry the pregnancy and was medically healthy and had a healthy appearing uterus, even if they were having irregular periods or they were perimenopausal, if they had a good embryo, let's say that this person who's in a same-sex partnership had a partner who was younger and created embryos with her eggs, then the person who's in their 40s could potentially get pregnant and successfully carry a pregnancy. Even people who are menopausal could get pregnant, let's say using a donor egg or things like that. So even when the ovaries stop working the way that they do when they're younger, the uterus, as long as it appears to be structurally normal, can successfully go on to carry a pregnancy. You can prep with hormones and things like that if you have a good embryo. So I hope that helps. Any other questions? All right. All right, well, thank you all for joining. Really appreciate you taking the time to be with us this evening. Hope that everyone has a great night. Please feel free to reach out if you have any questions or would like to schedule an appointment. And we would love to help you to build your family. Take care.